Good morning, everyone. Who zotted? Was there some zots in here? Excellent. Zot, zot, zot. That is the anteater for UCI. That is the University of California, Irvine's mascot. So anyway, welcome to this really exciting session, which we're going to be talking about transformation of public health and education to promote social justice. And let me just do my clicker. So I am a public health, I'm a social epidemiologist, public health practitioner, teacher, and researcher. And the mission really of public health has and continues to be optimizing, really just optimizing community health and wellness. And when we think about optimizing community health and wellness, we're really thinking about integrating health equity into everything. And so when we think about community health and wellness, we're thinking about equitable health and wellness. And so how do we think about doing that? And so one of the things that I want to share some stories a little bit about where I am and where we have been in the last year or two. But just to say that as a social epidemiologist, I've been doing stroke work for the last 15 years. And stroke is a disease of disparities. And so there's been a lot of work looking at differences in outcomes, risk factors, and morbidity and mortality by Black communities, white communities, Latinx communities, Asian communities, and this huge difference in disparities, difference in these trajectories. And so we've just been sort of chipping away at this and thinking about designing interventions that really integrate health and equity into everything that we do is really, really critical. And it's not just about a grand gesture. I am going to, work on health equity. The chipping away, and that's what the panel is going to talk about, is about doing something about health equity in every single thing we do every single day. And so when we're thinking about health equity and the drivers of health equity, we're talking about things like, to remind you, discriminatory policies, limited access to essential services and resources. We're talking about a history of racism and segregation that we really need to address and move. We're talking about poverty, which a lot of folks have talked about already, overcrowding living conditions, homelessness, chronic stress, low health literacy, and mistrust. And it's all of those things together that we really have to begin to address. So why now? And if you can see in this driver of health inequities, what do I have in the middle of that? I have a big COVID virus. And that's because despite the fact that a lot of us have been working on inequities for decades, COVID has done something. It has created a tremendous urgency around this. We are at a critical juncture now, and we need to transform. We need to restart public health. We need to move things forward. And so I really want to spend the next 8 or so minutes just talking about COVID, what we've learned from COVID, and how we can think about creating and transforming and shifting the paradigm when it comes to health equity for public health. And then my co-moderator is going to talk about this for education. And so let me do a little snap. So thinking about one of the first things that we learned at UCI, but I think that we learned nationally, is that even though COVID was a national disease, it became very local. And whether we're talking about an acute early response, the sustained response, or the recovery and resiliency, one of the things that we learned early on, and Paul mentioned, was that we had to get out there right away into the community and listen and act with and as partners with our community organizations, with our government organizations. What are the problems? How can we help? And one of the key things that we're, I think, really proud of, and I've spoken to public health leaders around the country, is one of the things that communities wanted was the early data. Hey, remember this? Why aren't we having access to testing, for example, when other communities don't? And that was sort of anecdotal. I can't get testing in my community, and I know they can. And so what we did as public health, as a school of public health really, is work with the community and work with community in collaboration, providing data, something that we've heard a little bit about. And then the community worked with that data, used it for advocacy, and guess what? We got more testing sites in communities. And so community, if we're thinking about, again, what is the shift? Community becomes important in that. The sustained response, how do we handle fatigue and burnout in that? How do we think about recovery and resiliency? Again, working with community. We did this, and I remember March, April of 2020, a number of things were happening. We had the social movement of Black Lives Matter, which highlighted the atrocities of excess deaths in Black communities due to police brutality. And at the same time, the great reveal, and I remember as somebody who does disparities work, sitting in my office and looking at real-time hospital data in Orange County and this huge trajectory of disparities by who you were, white, Black, Latinx. And I screamed. I literally in my office screamed, and I said, oh my God, we've been doing this for 15, 20, 30 years. This is not a chronic disease which we know is very much influenced by all of these other factors. This is an acute virus lasting 15 to 20 days, a terrible virus. Why do we have these disparities? And so we really need, what can we learn from that? That we have to call out each day in every way the structural bias that we see, and we have to take action to overcome that. Even the New England Journal of Medicine last year called out what they believe is a two-tier training system for clinicians, for residents, you know, that you get to see the resident if you're low income, you get to see the attending if you're high income, and what kind of training would that be? At the same time, and we've heard this before, we saw misinformation, burnout, overwhelming overcrowdedness of hospitals. We saw all of the rest of our chronic care basically going away in order to take care of patients who had COVID, not even allowing families into hospitals to be with their loved ones when they were dying. And at the same time, we're seeing this erosion of institutional trust coupled with policies that people don't understand, with health policies that are polarizing, and the lack of confidence about the defense of science. And so all of these things coming together, thinking about then how do we shift the paradigm, better communication, better communication. We need to use data in another way, working with communities. There are programs like Aim Ahead now that are bringing communities together. So to really think about electronic health record data and how we can use that to solve some problems of health equity, this paradigm shift of training students of public health to be able to defend science, to get out into communities. And the final thing that we really have to do when we're doing that, and I've heard it, and I was really very, very excited to hear everybody talking about a systems approach. We need to bring together communities, the public sector, the private sector, entrepreneurs, everyone, academic institutions, private businesses, everyone has to come together because, and we talked about, upstream. And this is I show all of my classes, this is a systems approach to flu vaccine, not even COVID vaccine, to flu vaccine. And so it's very easy to say, well, it's easy to get vaccinated for the flu. You just have to go to a clinic and hold out your arm, roll up your sleeve, hold out your arm, and get immunized. But really, it's all of the things in this system, all of them, that come together, that determine whether you get vaccinated or not. And public health alone can't do that, and education alone can't do that. We all have to come together, part of the human enterprise, and we have to work together and move out so that we have a future that is equitable and that is safe and that is healthy, where people have well-being, all people. So I'm gonna bring my co-moderator, who is the Director of Social Justice and Philanthropy for the Samueli Foundation, out, and she's gonna talk a little bit about education and the educational experience. Thank you very much. Did we lose her? Or did I just go too fast? Erin, please. There you go.
Thank you so much. What a beautiful experience. What a gorgeous room full of people. I'm so excited to be here. I'm so honored to come and get to share my perspectives. Thank you so much, Paul and the entire Illumination team, for putting on this event. It is going to be and is already such a transformative moment for these sectors. So I'm just really feeling honored to be here. So who am I and why am I here, right? So my name is Erin Samueli. Check her out. I used to be a public middle school teacher in San Francisco. I decided I wanted to be a teacher when I was 15, and I went full steam ahead with that career with an undergraduate and a master's degree in secondary science education. I have a massive passion for public education and the linchpin for change that space is and really functions as long as we are thinking transformatively about those systems. I'm really appreciative and grateful for the amount of times I have heard that kind of speaking in this panel and consortium so far. Every single panel, every single speaker is really thinking critically about the systems that are in place here in California, in our country, and beyond, and how taking a critical eye to those systems is fundamentally the way to change individual people's outcomes. So I was a public school teacher. I loved it more than anything. I still love it. I do plan to go back one day. But almost a year ago, I left the classroom temporarily to join my family foundation, the Samueli Foundation, and I act as the Director of Social Justice Philanthropy. So I am able to take all the lessons that I learned in the classroom, seeing inequity and playing out in front of me every single day, and apply that to a top-down approach and really think critically about how I can influence systems from the philanthropy space. So, what I have for you first. Oh, no, there it is. This is a photo of the school that I taught at in San Francisco. It's called the Claire Lilienthal School. It is a K-8 public school. It is a very small school, so I taught all of the 7th and 8th graders. I was their only science teacher. They had to see this face every day. Congrats to them. So I got to stand in front of this building that is on this image right in front of you and watch my kids arrive at school every day. And some of them arrived to school driven in Teslas by their affluent parents. And some of them arrived to school on a bus after an hours-long trip from the south part of the city. And both those kids were in my class. And both those kids needed to learn science from me. And it was my job as the practitioner to kind of facilitate that learning. And not only does each individual child have a specific learning style, but they also have specific backgrounds and home situations and personal lives that influence their ability to be successful in a classroom. And I had to manage all of those things individually as a teacher, and all teachers do, from K to 12 to beyond. It's really become the teacher's role to manage inequity in a way that I think is unsustainable. And I think one of the reasons we're having this conversation around not only healthcare, but also public education, is taking that systems approach. How do we take some of the stress off of individual practitioners and think critically about systems so those practitioners can do their jobs better, right? We want nurses to be able to do their jobs better. We want teachers to be able to do their jobs better. And the only way to accomplish that goal is to think systemically. So all the photos that I'm about to show you are photos that I took in my classroom of my own students in my own lab, so they're very sentimental for me. So this is a couple images of labs that I taught my 7th and 8th graders. You'll see low-tech things, you'll see high-tech things, but there's a large breadth of inputs and outputs to how my students are engaging. You'll see this is a really hands-on experience. And studies show that if students are given the opportunity to construct their learning actively, then they actually remember what they learned, and they can use that information, and they're galvanized to know it because they have a reason to. Some of you may be familiar with the Samueli Academy that my mom was instrumental in opening. I shed a tear every time I go because it's so beautiful to see those kids talk about whatever they're learning. And it is a project-based school that really focuses on putting that active role in the hands of students so that they can construct their learning in a beautiful way. Now, that requires funding, and that requires a lot of work on the part of teachers. I know, I experienced it. I had to set all these labs up. Do you see all those powders on that paper? My classroom was a mess all the time. But it was a joy to do because I got to see those kids excited about what they were doing and that I could facilitate that for them. Now, all that took a pause when COVID hit, right? There were a lot of implications for COVID. There was a lot of implications for who could access learning and who couldn't, who could participate in a home lab if they had the resources to, and who couldn't, who was able to find a quiet place to do their work and who wasn't. And we really saw that opportunity gap just get wider and wider and wider. It was pretty wide to begin with, but it is a chasm today. So all of those things really made me think, who are we teaching for? Who's designing our curriculums? Who's designing how our students engage? Are we including social justice principles in our curriculum design? Are we putting the onus of responsibility on an individual versus looking at a system? And so in my classroom, I took a really keen eye to teaching science through social justice and using that lens to say, you, 12-year-old sitting in my class, can be an agent for change in your community if you know about your community. And you can use data, I've heard that referenced a lot in today's discussions as well, to construct really robust solutions to societal problems, but you have to know what they are. You have to be intimately involved with them. You have to have a stake in them personally. Beyond that, I think it's on us as teachers and students to really incorporate a social emotional piece into this work. It is, at the end of the day, a very few number of my students will go on to be scientists, but all of them will be human beings. All of them will be family members, will be relationship partners, will be friends. And what am I doing if I am not facilitating that growth of the ability to not only think about my community, think about myself, think about how I engage with the people I care about, think about how I engage with people I might not even get along with. There's so many skills that are necessary to build in our populations that are systemically shut out currently. So really being mindful of that is so key. Another piece here, this is a silly photo of, on one side, our laptop cart. So I taught at a pretty swanky school. I'm not gonna lie to you. It was mostly high socioeconomic status, but a smattering of kids of other socioeconomic statuses as well. And we had a beautiful and robust tech program where there was one-to-one tech in each classroom. But I don't know if you can look at that image, not all of the slots have laptops. There are holes there, there are gaps there. So even though I taught at a really, really ritzy place, it was not what those kids deserved. And a lot of times, you'll see on the right, there's a pencil that says, "Return me to Miss Samueli's class." I had 500 of those pencils made at the beginning of the year because what does an 11-year-old do when they show up to class? They don't have a pencil. And is it an 11-year-old's job to always carry a pencil with them? Is it my job to be like punitive when they don't? But it's my job to facilitate their learning, so for me, what that meant was buying 500 pencils at the beginning of the year. But what if we can't afford 500 pencils at the beginning of the year? Teachers are consistently taking money out of their own wallets to supplement their students' education so that they can try and level this playing field. But that's egregious, if you ask me. I was given a stipend to support my students because I taught at a fancy school. Think about all the kids that don't get that stipend, and they're receiving a lower tier of education as a result of that. I'll close with an example. So, the country of Finland, I know, random. The country of Finland has the #3 best education system in the world. And they really examined why that might be. And one of the reasons, at least I think, is that teachers are revered in that society. They are viewed on a level playing field with doctors, with the leaders of society. And when society believes in its teachers, the teachers can then believe in those students and create this cycle of uplift. Now, that might not seem like a big deal, but that is really confronting the systems in place here and saying, whose voice matters? How do we co-create solutions, not only with teachers, but with students, with families, with people whose voices have not been valued in this conversation? How do we get them involved so that we can all be change agents together? If we can uplift teachers and school systems, we uplift students to become agents of social change for the next generation. So without further ado, I am honored and delighted to bring on our completely female nurse of color panel. Yes, can I get applause for that? Stunning. First, we have Dr. Pooja Bala, the Executive Director of Healthcare Services at the Illumination Foundation. Thank you so much, Pooja. Next, we have Mary Sanchez, Manager of Clinical Relations at West Coast University. And finally, we have Dr. Danielle McCamey, Founder and CEO of DNPs of Color, Assistant Dean for Clinical Practice and Relationships at Johns Hopkins University School of Nursing.
Great. Welcome, panel. Can everyone hear me? Okay. So, Mary, you have the first question. Well, Erin just talked a little bit about education. I talked about public health. Can you provide the audience with an overview of the connection between public health, education, and social justice?
Oh my goodness, I think they go hand in hand. I would guess, and the comment we made earlier about moving out of the way for nurses, it's true because we see it frontline, and the need to, and that's part of our oath, right? The minute we see someone, it's to do them no harm, and we accept no judgment. We take care of it, and so the social justice is in there. Unfortunately, there's a big, broad problem with it, and it starts with even in our educational system. Public health is not revered for a lot of nurses when they come out of school as being the place you want to go to, because you want to be in the ICU, the ED, and all that sort of thing. So understanding that we want to keep people out of and start taking care of the people and the children first, so that they never get to the point where we have homelessness, is the most important part. So those are interlinked strongly.
And just to follow up to that question, thinking about, again, what Erin talked about, thinking about public health, thinking about nursing and education, these, the last two being professions in which really there's a big dedication to health, well-being, and to social justice. But what about the concept of something like public health civics, so that from early childhood all the way through higher education and into professions, that we could really link public health and social justice? And I don't know if you want to comment or any of the other panelists want to comment.
We discussed that, so I'd love her to.
Yeah, I think we're a panel of nurses here, so we were just kind of naturally just coming up with all the solutions, right? But we did talk about the value of educating early on about public health. Within my particular specialty in academia, we're looking at exposing nursing students to public health and the importance of health in the community, and ensuring that nurses are everywhere where people are located, and really instilling the value of public health, community health, population health, and also looking forward as healthcare is evolving to where we're going to be taking care of people that have chronic long-term conditions in the community more so than the hospitals, because the future vision is that the hospitals will be reserved for those acute patient cases. And so structuring nursing education to really support and instill the importance of the community health early on, so that that takes on the culture of nursing, which is the very center and core of our values as nurses.
I really appreciate the perspective of really focusing on the community first, that human-centered principle to see, what gaps exist as described by the community, and how can we work at filling those. I think we can all identify that one of the greatest gaps that does exist is representation in these key fields. So Dr. McCamey, I would love to hear, how does a lack of diversity in the healthcare workforce affect health equity?
For me, it's plain and simple. If we don't have healthcare providers that reflect the lived experiences in the communities that we serve, it's hard to make that connection. It's hard to establish that trust. It's hard for, with the lack of trust, it's like a domino effect. It's the patients and families don't necessarily want to adhere, not because they don't want to, it's because the lack of trust. And then also speaking the language. A lot of communities of color, we have our own language, whether we're non-English speakers or me identify as a Black woman, we have, urban vernacular. And so sometimes the medical jargon can really be intimidating and puts us on defense. And so we can't really relate or understand. And because of the lack of trust, we're not so apt to want to ask questions, but look to, I know for me, I am the clinical ambassador for my friends, families, cousins, church, because I'm an acute care nurse practitioner. So they're like, call doc. I'm known as doc. So I'm a trusted healthcare nurse in our community. So really looking to diversifying nursing and healthcare in general is really important so that we can really connect to the patients and families we're serving.
And Pooja, Dr. Bala, when we talk about a transformation of public health, does that include taking medical care back into the community, sort of thinking about medical house calls of the past? How do we think about that paradigm shift?
Yeah, we witness this every day when we take care of our patients who are experiencing homelessness, from adults to kids. On any given day, we are seeing our patients in our settings where they might have health insurance, or they don't even know they can get health insurance. They don't know how to sign up for benefits. What we've learned over the past several years that we have to bring services to them. Access to health insurance does not mean that they're actually accessing healthcare services. And I would encourage all of you to come visit our facility tomorrow. If you haven't signed up, please do sign up. We have created an integrated care delivery model here in the city of Fullerton, where we are bringing services to people where they live. They have to be brought to them where they're residing. Many of the speakers earlier spoke about the social determinants of health issues. Folks aren't accessing healthcare because they have many other competing priorities. Where are they going to sleep? What are they going to eat? How are they going to be safe? So we do need to take care back to where people live, and we've been working on that for many years. I did this work in Boston where everything was about we've got to go where people live. And of course, during the pandemic, we saw that firsthand. Many, many untreated issues led to so many deaths for folks where if they were in the healthcare system early on, they could have been better outcomes.
Just to follow up to that, in thinking about going back into the community, in thinking about house calls, are there other jobs that we can create in the community that are sort of transitional, that really help to get healthcare back into the community, and what would those be?
Yeah, great question. And many of our folks who actually have come through our program that have a lived experience are now community health workers who are now getting us back on track, because they're the folks out there building the trust with the clients to get them to, let's go in, let's see the doctor, maybe
That's
just take a
awesome.
few minutes, talk to them. So there is a whole slew of disciplines that are being left out of the equation that can really help us solve this healthcare shortage that we're facing and will continue to face. And about 25% of our clients who have actually come through our service model are now working with us and are now giving back to the community. And they are a core portion of what we do. We could not do, what we're doing today. In fact, in California, with the new CalAIM program, there's a lot of effort on bringing services to clients, and outreach is a big component of that. And those community health workers are critical to that function.
That is such a beautiful representation of getting the need where it is, meeting the need where it is, having that asset-based, values-based perspective, and saying, we are here for you. What do you need? I think that is so key, especially in populations that have been systemically shut out of the healthcare system, as you were sharing earlier, Dr. McCamey, that we need to show them that we value them for exactly who they are. Who they are is valuable and valid and exactly who they should be. And I think this absolutely extends to our homeless population. So I have a question for you, Mary Sanchez. The senior population is among the fastest growing homeless populations. What are some of the special needs of these vulnerable seniors that can be addressed through the transformation of public health and education?
Well, we were lucky enough, if you will, when COVID hit, the pandemic, that a organization called us and said, we have 450 seniors that are shut-ins now, and they need us. They need us for food. But interestingly enough, goes back to what you're saying, food is important and you've got to have it. But what we found was loneliness is just as was an epidemic. And as you know, with seniors and children, well, with all of us, but we saw it. Just to have somebody that they came to their door and they'd stop. Can you talk to us? Or let's talk about the weather. Whatever it was they wanted, but they wanted the human touch. And that's where I think nurses, we talk about that, but that's what we do. Yes. And I hope they never take that away. And it doesn't become robotic. It becomes even more important in this world right now, especially with what we came out of. So hopefully you answered that. I would say touching, seeing them, being there is probably the most important thing we do in public health for them.
And really going from where the human touch, and that's something that, nurses have been doing forever. That is really, the sort of constant, the value system. So how do we think about everything that we've learned because of COVID, and human touch is absolutely one thing, but everything else that came out of this? How do we think about nurses as being the backbone, sort of linking public health, linking education? Dr. McKee.
I think the pandemic underscored the importance of nursing and the value we contribute. And if you think about it, nursing has been the trusted profession for the past 20 years, according to the Gallup poll. There are about 4.3 million nurses, making us the largest force in healthcare industry. So really leveraging our trust and leveraging the force that we bring helps us to be important to shape the value in healthcare to make these outcomes much more positive and equitable. So looking at education, Mary and I, we were talking about how can we get nurses jazzed about public health and community health. And I know at my institution at Hopkins, we are strategically making a deliberate steps to make it part of our curriculum that the rotations that we offer students, we start off in public health, community health, because nurses need to be found where people are, and people are everywhere. It's what my dean says all the time. People are everywhere, and we need nurses there too. So really structuring education so that we start thinking the importance of public health, because the pandemic underscored when the most marginalized and disenfranchised are without, we all are impacted by that. And then policy. Get out the way and let nurses lead. Thank you, Lisa, for that. Hashtag, I'm getting a t-shirt with that on. But I'll credit you, Lisa, wherever you are. So we're starting to see more representation of nurses in Congress, and because we think with a different lens. We have that people-centeredness that's ingrained in our soul because it's our calling to become a nurse, and then our curriculums help build that out for us. But they're bringing forth different bills, such as the FAN Act, which basically gives a ton of money to help diversify nursing faculty, nursing education, so that we can start having faculty that look like the nursing students we want to attract, that end up going out into the industry to serve the communities that are diverse populations. And then just partnering with organizations that are doing the work. Why are we reinventing the wheel? Look for organizations that are focused on communities of color. There's the National Coalition of Ethnic Minority Nurses, NCMNA. There's the National Black Nurses Association. There's Diversity CRNA. There's DMPs of color. We're out here helping to provide resources, building communities, and mostly creating opportunities, because a lot of times what happens with communities of colors and those that have been historically racialized, we don't have the network or the community to help us get into these different places and spaces like Disneyland Hotel, the list goes on, but I'm going to stop there. But that's kind of like a little bit of my soapbox.
So just to add on one question, so I'm going to be selfish.
Yes.
As a dean of a soon-to-be school, but a very large program in public health, where we are training, we have 1,300 undergraduates in public health and another couple of hundred masters and doctoral students in public health.
Yes,
I want to
run
talk
it down,
about how,
Dean. Love it.
but how can we do this together?
Easy. And that's one thing that we're also thinking strategically as a School of Nursing at Hopkins, is crossing across the different schools. And I think it was Sheriff Barnes said, why are we looking and saying all of our needs when we can just look next to each other and say, what can we do that mission overlaps to work together to increase our impact? And so leveraging the different specialties and expertise and finding ways we can partner for our mission to move forward.
I really appreciate that emphasis on collaboration. Yes. This is something that I am grappling a lot with in the philanthropy world, because philanthropists really want to be the creators of that key program that changed people's lives. And I think there's a lot of merit to that. But just like you said, there are people out here in communities who have been doing the work for decades, doing it stunningly, better than we could ever hope to. And instead of going in and saying, I'm going to recreate the wheel, collaborate. Yes. This exists across all sectors in education, even among teachers in one school, across multiple schools, across sectors. Collaborations and partnerships are what bring us to our goals in a way that feels the best for everybody, because everybody has a seat at the table.
Absolutely.
And I think collaboration was something that really came to the fore during this pandemic, right? We were all stuck in our houses. We could collaborate via Zoom. I know that's no one's favorite. It's not mine. But it really drew attention to the need for human connection and how to use our collective unconscious to create the most good. So I have a question for Dr. Pooja. I'm such a The View right now.
I love it. I love the vibe.
Living for it. I matched the couch too. It was really good.
Facts.
So, Dr. Pooja, what do you believe the COVID-19 pandemic has taught us about public health in the U.S., both good and bad?
Yeah, well, we've all heard the quote from Winston Churchill. It's that, don't let a crisis go to waste. And that's what we learned during this crisis, that we are a broken healthcare system. We need to work on our public health side. We need to be working more upstream. But the good, and this really does impact all the work that we've done and will continue to do. Right at the beginning of the pandemic in Orange County, the healthcare agency came together and they decided to run a COVID response program. They did it right from the beginning. We ran the Project Room Key, now called Project Home Key Project. And sadly, we had about 3,500 folks who came in through the COVID program. But I'm really honored and humbled to say that, as far as we know from the data, there were about 16 COVID-related deaths. So many thousands of lives were saved through this program, and we're thinking about tackling homelessness. During the pandemic, we were able to bring people inside, bring them into services, keep them from dying, do what needed to be done. And I think that's what we learned, that if everybody collaborates together, where there's a will, it can be done.
So one of the populations that we haven't talked enough about, which very vulnerable population, are our children. And they suffered terribly during this, in terms of education, the educational experience. There was, we will see over the next decade this huge disparity between children that really had the support when they were home and children that did not. So Mary, how do we think about childhood trauma? How do we move forward and think about interventions? And this is the crossover between, I think, public health and education.
A side note on that. A few years back, I was able to work at a clinic in South Central LA. And I don't know if you remember the story, the news story, but they found a child that was living on the roof of the school because he was homeless and too embarrassed. So he'd be right. So childhood thing is very big for many of us that I work with, and it comes to the education. And the only way out, I think the best way out, is for a child to have an education, and also to dream. You can't dream if every day is a trauma around you. And that same place that I went to, that high school, there's a sophomore in high school, and I asked him, tell me, about your, going home, what it's like for you. And he said, I just try to think about how to get home safe. And I thought, man, I never had to worry about that. I don't think many of us here ever had to worry about that, or our children. And that was sobering for me to realize that and we know statistically that the ACE scores, for those that need to look that up, but it's adverse child events, when they're 4 or greater, is it 4 or greater or 3 or greater?
4 or greater.
4 or greater. They have more likelihood of staying in poverty, of the employment, never graduating from college, and so their life is already set for them in a very sad way. So we have to get the children involved. We have to be the front line. And as nurses, since for 20 years, I was just talking to the doctor about that, 20 years we're the most trusted profession, yay. So they're the ones that will come and talk to you. I found that too. So we need to take that to our advantage and utilize taking care of the children first.
Dean, if I could just add to that, we're talking about childhood trauma. So we run programming for kids experiencing homelessness. We see a lot of families. And sadly, when we look at our data, and we've been measuring this along the way, the average ACE score, that measures adverse childhood experiences, toxic stress, for our kids is 5.6. And many of those kids are under the age of 5. So you can just imagine, these kids are living in these places where they're not even sure what's going to happen next. And here we are, we have Dr. Grover and Dr. Kennedy from our CHOC team who's really helping us address some of these issues for our kids, because these are kids of parents who've been experiencing generational homelessness for many, many years. We talk about street homeless. We've got lots of folks who are still living on the streets, living in their cars. Safety, security is a big issue for our kids, and we're trying to really figure out how do we try to meet the needs, and where do we actually start? Because there's so much going on. It's housing, it's food, it's healthcare, all these things, and we've got to all work together to address some of that.
So both of your comments really made me think about Maslow's hierarchy of needs. And I think if you've been in a 9th grade English classroom, you've probably heard of Maslow's hierarchy of needs. And it really is a scale to determine how able an individual is to self-actualize, to become the best version of themselves, and to do so unimpeded by life's barriers and systemic barriers more than anything. And I think I know for a fact, if you were to look at the proportion of people who were able to ascend Maslow's hierarchy of needs, there would be some very clear trends in that data. We know that I'll focus on children right now. We know that our economically disadvantaged students are having trouble with that ascension. We know that our Black and brown students are having trouble with that ascension. And we know that the systems in place are actively contributing to that challenge. And so with all of these systemic barriers in place, we know that communities of color are disproportionately affected, specifically with negative healthcare outcomes. And we also know that that comes from all of the other pieces of that puzzle, from housing to income to transportation to childcare to food security. All of those things are connected. So Dr. McCamey, knowing those things to be true, what systems level changes are necessary to change this equation?
Oh man, there's so many things, and we have a whole consortium directed for that. But some of the things, like I mentioned earlier, collaborating with the grassroots organizations that are doing the work, so we're not duplicating efforts. Looking to, like I mentioned earlier, like structuring our education so that it meets the needs and the challenges that we're looking at in healthcare now.
Real quick, we got a question from the audience that dovetails to this perfectly. So, we talked about the lack of diversity at representation in the medical field. Kind of tackling on to what you just said, how do you really tackle systemic issues that prevent people of color from pursuing these careers? Inequity in the educational system, financial inequity. I mean, I know we're asking you the biggest questions in the world
Seriously?
right now. No pressure.
But this is a part of where my passion is with my nonprofit DMPs of Color. We focus on building community and creating opportunities. Like I mentioned before, a lot of times we have to create these spaces that focus on people of color because the system has been designed to exclude us and not offer us any opportunities. And so we've had to create these affinity groups, if you will, these affinity spaces where we can leverage our network and find that source of support and community to gain confidence to go out in the systems and the structure that continue to beat us down. I mean, hashtag Ketanji Brown Jackson, if you watched that whole ordeal, even when we are exceptional to all the rules, even when we do have the accolades, there's still a lot of pressure that exists to deny us what we're qualified for. And so groups like DMPs of Color and other ethnic minority-focused groups, creating that community helps build us up so that we can be able to function in spaces like this. I mean, I am standing here representing my mom who raised us by herself, and I was told that I would never make it to college because of being Black, poor, and not scoring over 1,000 in my SATs. And so having that narrative in my head play out and not having the communities of support to either tell me the game secrets, which at the time was my track coach that was like, we're not ascribing to that narrative because you have all these other things that make you a viable candidate to go to school. So having allies and those that see the potential and can leverage their networks for communities of color so that we can have the opportunities is so key so that we can have access, be sponsored, and represent and shine. Because I always say when I look at my community of DMPs of color, we just need one opportunity and we grasp hold of it and we soar. But leveraging networks that we don't have is hard. And so that's why it's important to have the communities of color to support and foster that, that excellence, that confidence, and help us navigate these structures that are invisible and visible.
And I just want to push this a little bit further. So what are the other opportunities, and you can answer, anyone else on the panel, what are the other opportunities? We talked about a systems approach, and I think we all agree that a systems approach is critical, and there are barriers, structural barriers, but
Yes.
who are the other partners that we can bring in, even for the question that you just answered, beyond a supportive community of color, who else needs to be part of this?
I'll pass it on to my co-panelists.
Yeah, I mean, I think a big piece of it is our policies, right?
Yes.
We got to start at the top. The policymakers need to all be on the same page, and there's a lot of great work happening around the country, especially here, where we're now bringing in resources together to address homelessness, to address healthcare issues. And a big piece, going back to kind of the nursing theme for a second, there's a famous saying, all the nurses in the room know, nurses from the bedroom to the boardroom, right?
Yes.
We are good at solving problems. So we need to kind of keep moving forward with that. It's been a long time coming where nurses are in executive level positions. They are at the helm of trying to solve these problems, and we need to do more of that.
And I just, one other question about nursing and nursing cohorts. So the nursing cohorts of 20, 21, 22, they were really on Zoom or with very limited community engagement and even some limited clinical experience. So what advice do we give these new grad RNs for getting out there and really trying to make these changes without that experience?
Well, maybe I could say not give the advice that I was given 25 years ago, almost 28 years ago when I was coming out of nursing school, which is like, oh, don't go into the community, public health, there's not a career there. You gotta keep going, go to the hospital system, the major healthcare system. And that was my introduction to working with the healthcare for the homeless space. And my mentors was, thankfully, I found the right person who's like, there is a path forward. There is a journey, there is a career in public health and community. But the advice I was given was very different at the time.
Yeah, it's within. And we had a discussion about this last week. Even our own instructors, so it is within, that feel you really haven't punched your card until you've worked in the acute care setting. And we've got to get away from that. That's probably the biggest thing. I want to add one thing that you were talking about earlier, because everybody here wants to say, what can I do? There's been all kinds of studies shown that kids out of the worst of situations, the worst, parent abusive or incarcerated, whatever, if there is one lifeline, one person that they can hold on to, it has made the difference between not making it and making it. And so through Boys and Girls Club, whatever it is that you find through your church, that you adopt in a way a person that just you know needs help, that can make the biggest difference in their life. And I think that that's probably the best advice I could probably give this group.
And I just want to add, because I think that the community engagement, community participatory research. So I ended up getting into community participatory research a long time ago. I'm not even going to tell you the year, because then you'll know my age, and there's no way I want you to know my age. But simply because I was asked to look at the incidence of stroke in a community, in a very diverse community in northern Manhattan. And to do that, really needed to know not just who came to the hospital who had a stroke, but who didn't, and why they didn't. And so I just went out there. There was no mentor. Just went out there and started talking to community. And then the NIH came out with the Clinical Translational Science Award grants. I know you're shaking your head. A lot of you know it. And because I was the only one in academics who was an assistant professor who had done community engagement, they made me the director of that. And but here's the interesting thing. The faculty, and I was, going on that tenure track academic, they came to me, faculty mentors, and they said, under no circumstances is this a good choice for you, because you'll never get tenure. That's what they said. So if I were you, I would focus on getting grants, writing papers, and teaching, and just let somebody else who has no ambitions do community engagement. And, I thought about that, and I said, but this is the heart of public health, action and communicating and partnership with community. So my mentors were wrong, but I do think, to your point before, that we have to be very careful because people are still being pushed back in terms of career movement forward because they're doing community work. And so that is a bias that has to be brought down.
Yep. Absolutely. And if I may add, because I think this is such an important question, especially around what you brought up with what can we as individuals do? I think everyone on this panel at one point in their lives has been told something as the voice of a system. The voice of the system says, you should not do public health work. The voice of the system says, you should not be in these communities doing human-centered design work. And if I may leave everyone with an action item for today, is to have a critical ear to when you as individuals, which you all will be, are told sentiments of the system that either don't serve you, don't serve your communities, or don't serve historically underrepresented peoples, and to push back against those norms. Individuals feel powerless when it comes against systems, but when individuals work collectively, that's when systems change.
Right.
And that requires everyone to use their voice and use their critical minds and use their hearts and their compassion as their driving decision makers.
That's right. And call it out. Yes. Don't wait. Call out the bias.
Yep.
Yes.
It may be uncomfortable, it may be awkward, but if you don't call it out, it's never going to get addressed. Who's the next question asker?
I know, we got a little off track, but it was a stunning tangent. I have no regrets.
No regrets.
The next one is you, question number 9.
Oh, no, I don't even know where question number 9
Right.
is at this point. Let me see. Okay, Pooja. How big of a factor should data collection and analysis play in the transformation of public health? And who should pay for that?
$1 million.
It's huge. Who should pay for it? Let's start with that. I think it comes down to the private-public partnership. It has to be done together. There's not one way to tackle this. And we, at IF have really been data-driven, and that's how we've been building our care model, and that is why we built an integrated care model, because we were seeing from our data that our folks are using the emergency room to access the healthcare system. So what we've been able to do with artificial intelligence, really look at utilization of our clients when they're going to the emergency rooms, how much time they're spending inpatient, what their medical issues are, and really track that along the way. We worked with, our partner CalOptima to get that data, and now we are working on what we call predictive analysis. So data is huge. We can actually see, and others speakers before spoke about this, that we can actually predict who is going to end up being homeless. What can we do to prevent that? We're now looking at our models where we can start tracking that along the way and keep people out of the emergency room, keep them in services, and not use, already burdened emergency rooms for things that are secondary gains, where a person might just show up there because they need a bed. Let's get them into housing. Let's get them into shelter and services. So we need to definitely be data-driven and build and be informed about how we build a care delivery system.
So I alluded earlier to data and to an evidence base and to the erosion of confidence in the institution of science in particular. And Erin also alluded to the fact that we don't even teach science well. This is for all of you. How do we defend science? And how do we train our students, whether they're nursing or public health or just students in general, to defend science and, to try to move forward with science?
Yeah, I mean, I think it really comes down to the conversations and looking at those studies that have been done and what we've learned from that and use that for future, and we don't talk about that in school. How do we change the education system to inform what it needs to look like? And we got to go back and look at the history and see what did we learn from it? How can we fix it? We got to just keep it at the forefront.
Yeah, I would agree. Keeping science at the forefront, but also people, I don't want to say undervalue nursing science, but putting more value on nursing science. I mean, we think about the Mary Seacoles and the Florence Nightingales and their primitive thoughts around science and how it's bolstered up into a magnitude of nursing science. So I think, like I said, just putting more value on nursing science and the evidence, but also making sure that the evidence has a diverse voice on it as well, because who's doing the research studies? Who are they studying on? And are diverse voices represented is another challenge, but something that we should also keep as a focus of importance to make sure that the science is representative and applicable to the communities we're going to be caring for and managing.
Anything to add?
I was actually going to talk about evidence-based. That's what we claim to do as nurses, but you brought up the minority part, and it's very, very important. Yeah.
If I may add, I think also it starts at a very young age. You want to build a really positive association with science from the get-go, and I alluded to this in my introduction, but centering student voice and student identity in those conversations.
Facts.
I mean, I think we all remember sitting in a middle school classroom having a teacher just drone on about something, and I challenge you to restate anything that teacher said. Crickets, yeah, exactly. But if that teacher asked you what mattered to you, and then taught you about the world around you and made you an active part of that conversation, how could you not want to learn science? How could you not want to use it to make the world better around you? And so I think that starts in kindergarten, but it does not end in 12th grade. The university component of that is so huge, and that's when you get to involve these huge, important data sets about the communities we live in currently. Because what is more galvanizing than knowing that down the street in Santa Ana, a lot of their soils are contaminated with lead? So if they try to make a community garden and feed their communities, they're gonna get lead poisoning. Now I care about that. Now I wanna use science to solve that problem. But if we didn't put ourselves and our communities at the center of that conversation, you would just talk about, you would be lectured. It's just not the same.
And that's right. And we're trying now for our public health students to have them be the defender of science at every Thanksgiving table, right? Because there's always at that Thanksgiving table people who don't believe in science. Yes. So how do you get them to do that? How do you give them the confidence? And to your point, Erin, context, place matters. The story, the narrative really, really matters.
Absolutely. All right, I have another audience question here that I really, really love. It is specifically for Danielle, but I will present it to everyone in the panel. So what pathway or solution do we think would be successful in empowering BIPOC patients to be partners and advocates in their own healthcare journey? So not necessarily looking for a career, but sitting in a doctor's office, experiencing challenging healthcare, how do we empower that individual to be an agent for their own health?
Oh man, y'all really trying to rev me up, and because it's multi-layered. Because I had an experience where my partner has long COVID, and we went in for a follow-up, And the physician came in, and he didn't even give us any eye contact. He's like, yeah, I see that you have long COVID. I'm referring you out to a pulmonologist. And it was just like, he didn't take the time to do a review of systems and a physical exam. He didn't even have a stethoscope around him. So I'm just sitting there like, he has no idea what I'm about to unleash on him right now. So I just sat there and I was like, let me give him a chance. You know, he's rustling the papers, and the next, he's writing all these scripts and these medications. And I'm like, I really appreciate that you've come in already with an assessment and a plan, but can we start from the beginning and get the history just to see how well they're doing, where we're going, what are our concerns, what resources we would like to engage and tap in for support, because long-term disability, all the things around long COVID. And he paused and he was like, oh, so you must have some sort of medical knowledge. I said, yes. I was like, I'm a doctorally prepared acute care nurse practitioner, and I feel like you're not doing your job as a physician who we are trusting to take care of us, so I don't have to put my critical care brain on and call you out on all the things you're doing wrong, so that I can rest at ease at knowing that we are in good hands. And so then he busts out the stethoscope, and I was like, no, you don't even have to humor me. Like, we're going to go elsewhere. But that's with me, because, that's with me, and I have the education. So I always, go to sleep with this $1 million question, like, how do we empower those that don't have those advocates to speak up when they know that something is wrong? Because my partner, he left there just so discouraged, like, thank God you were there, because I just kind of shuddered and was just like, well, I guess I don't need to ask any questions because the physician has already made up his mind. Yep. And so, I wish I had the answer to that. And whenever I encounter patients, especially in the ICUs, I always tell families, I said, we do this every day. You did not have to go back to school to come and help take care of your family member while they're here in the ICU. If there's anything that you're uncomfortable with, that you feel like we're not paying attention to, you have every right to pull us at our coattails and say, I need you to listen to me. And I always tell my family and friends, if you know you're going to be in the hospital for more than a day, you need to find out who is the patient advocate of that hospital system, and you need to also find out palliative care, because palliative care, you can get a lot of backdoor services and support with the use of palliative care. But to go back to the question, what's the $1 million answer? I wish I had that, because I will be rolling in dough right now.
We have 34 seconds left. Okay.
Well, and I do want to just say something to that. And here I go again. It starts with teaching them very young. And you talked about that at 3 years of age, to stand up and say what they got to say. And kindergarten, when somebody says something in a respectful way, that's where it's going to start and change. I really believe that.
So I think I'm going to end with the question. Pooja, do you want to say?
Good.
End with this question, which is just a general question for all of you. And one of the things that was brought up early, one of the things that really resonates when we think about nursing as a career, and that's compassion. And I think we should end it on compassion. And so what's the role of compassion, and how do we teach compassion?
Well, my definition and thoughts on that was just provide opportunities for people to be vulnerable, authentic, and accepted for their humanness and personhood. I think that we get caught up in the rigmarole, and we box people, we label, and we don't take the time to even just ask, how would you like to be referred? What are your pronouns? Like, how can I make space for you? I know for me as a Black woman, I'm in a lot of spaces and I'm the only one, and I'm looking around. So even being invited or being seen, saying, hi, what's your name? I see you. Like, let me introduce you to all the people and all the things. So that would be my contribution.
Thank you.
And I guess, when I think of my patients, I always think about the one thing they would always say, you actually took the time to listen. I think most important thing is listening, seeing beyond the person, trying to understand their story. And this is why sort of the world of healthcare for the homeless exists, because many of our patients were totally isolated from the mainstream healthcare system. And that is why organizations like ours started, because they were not being seen in the mainstream system and they don't trust the system. So being there, listening and caring, for those in need is really key.
I think that when we talked about compassion, it's something as simple as, the expression to know someone is to love someone. And I honestly believe that if you took the time, like you said, and made yourself vulnerable to listen, and I think that's a huge part of compassion. And I've seen people that were very cold, and I thought never would they do after they open themselves up. So I do think that's a good point she made.
Yeah, I think I've heard the theme of vulnerability coming up with all of these answers, and I think that's really key. And I'm going to challenge us who show up in spaces as the leader of that space, as the teacher in that space, as the facilitator, to show up with that exact same level of compassion. Because if you are asking a room full of people to be vulnerable, you must also model that vulnerability. You must also show them that even though I am the one with the accolades and all of the people coming to hear me talk, I am equally in this game with you. We are all working towards a shared common goal, and if we cannot all share our vulnerability with each other, then how can we hope that our students or audiences would feel the same way? And so I think this comes back to education in a really clear way. Teachers need to show vulnerability. Teachers need to facilitate real, authentic conversations, need to model conflict resolution, need to model the soft skills all the way through the university level, to where you have a student come up and see you during office hours in tears about an assignment you gave, and instead of judging them for it, you say, I see you, I hear you, I value you, and we're gonna get through this together. That's how you teach compassion.
I want to thank the whole panel and Erin for everything that I've learned today, and I think for everything that everyone else has learned today, and you provided tremendous insight. And so, time for lunch.